Welcome to this CTSnet roundtable discussion with presidents and leaders in their field in cardiac surgery. My name's Joel Dunning and I'm delighted to be joined with four people who are outstanding people in their field to talk about current developments in valve surgery. From my left we have Professor Francesco Musmecci, Professor of Surgery at San Camillo in Rome and the next President of the Italian Society of Cardiothoracic Surgery. We have Tim Graham, a consultant cardiac surgery at the Queen Elizabeth in Birmingham, and our current President of Society for Cardiothoracic Surgery in Great Britain and Ireland. We have Mr. Vinny Bapat, a consultant at Guy's and Tommy's, and I'm very jealous about the fact that he has created an outstanding app for the iPhone on valve-in-valve surgery, which I use very regularly. And we have Professor Paul Herregers, Professor and Chairman of the Department of Cardiovascular Surgery at KU Leuven, and President of the Belgian Association of Cardiothoracic Surgery. So thank you very much all for coming. So we're going to talk about the very sort of best that we have in valve technology, and I suppose really 80% of valves these days are biological. So perhaps first of all I did want to talk about our stented valve technology. Professor Herregers, I don't believe myself that all biological valves can possibly be the same and all last 20 years and then all stop at the same rate. There must be a difference between valves. I mean, what are the differences, and is it treatments? And how do we tell the difference between our valves?
Okay, of course there's a big improvement last years in the valve technology that is used especially to treat tissue. What we've seen in an all-comer inclusion study of about 600 patients is that those valves that have a small effective orifice area and high gradients and are not treated with an anti-calcification treatment, they have very fast structural valve deterioration. Especially the combination of a high gradient and being non-treated is really detrimental for this valve. So most companies have developed an anti-calcification treatment in different stages, and now they come to a high level of perfection. We recently have studied subcutaneous implanted tissue patches from the most frequently used valves, for example, with Crown PRT, the PRT treatment, compared this with links from the trifecta, and compared this also with Thermafix as in the Magna Ease, and those three significantly reduce tremendously the calcification potential of these patches, and approximately to the same level. There's no more significant difference between these three. So this means if you have a large effective orifice area and a well-treated modern anti-calcification treatment on the tissue, you can expect a longevity of 15-20 years of this bioprosthesis.
Yes, and Francesco, in Italy, how should we choose the best stented biological valve for our patients?
Well, I must say that there is quite a variety according to the surgeon preference. So there is, again, I think it's very much left to the individual surgeon, considering that the valves that are available on the market today more or less provide good early and long-term results.
And Vinny, we've got this new extra dimension. It's a biological valve thinking about the future, and the future might be a TAVI in 20 years' time. What would you say, in your experience, helps for future valve-in-valve?
So I think the valve design, if you're thinking of what we're implanting, is changing, and still, although the sutureless platform, which I think you directed me to, is definitely one which I feel hemodynamically may be much better than the stented valves which we implant. However, of course, there is an element of not only cost but learning curve and applicability. So I think there's still a lot of scope to improve the stented designs which are currently available, because there are still going to be a large percentage of surgeons implanting those stented designs. So I think there's a lot of effort from the industry as well. It's not just the effort is towards sutureless, but also to make how the stented designs can be made more TAVI friendly in future.
Yeah, I mean, valves like Mitral and things, they have quite large orifice areas. Is there a difference between valves that mean you really should think about that when you're choosing a
Absolutely.
valve?
So as there's a lot of pressure from the patients, a lot of patients don't want anticoagulation. But more so as the patients are becoming aware of so-called valve-in-valve treatment, more patients come to our clinic now wanting a biological valve. My current preference, if I may say, for the patients is I prefer to put a biological valve, at least alert them that valve-in-valve is only possible if I can implant a larger biological valve. So if I cannot implant a larger biological valve, I think I do educate the patient that he may not be suitable for valve-in-valve in future.
Yeah, and Tim, in the UK, when you're selecting a valve, you use a lot of sutureless valves, I know. Do the cardiologists have a different view on long-term durability to us? We've got 20-year data on our aortic valve replacements, and yet to them, lasting 4 or 5 years for a TAVI seems okay. What do you tell your patients when you're talking about biological valves?
I usually tell them that I think they've got around about a 75% chance at about 15 years post-implantation of being free from structural valve deterioration or problems with the valves that's going to require a re-intervention. Clearly, with the increasingly aging population that we're operating on, quite a lot of patients actually don't get through to that age.
And Professor Musmeci, do you think the fact that we do have much longer term data on our aortic valves, that makes a difference in our selection compared to TAVI currently? Or do you think this is going away as an argument?
Well, certainly on the TAVI we still lack of long-term results, and I think it is a very important point. While on stented biological prosthesis we know that we can sort of have up to 20 years according to the age of the patient when the valve is implanted, sort of in terms of valve duration. So certainly I think this is an important point. But as I was said before, the concept of a valve-in-valve is really coming to the equation now. So when we decide which valve we want to implant on a patient, certainly we'll consider not only the duration of the valve, biological valve, but the option of a valve-in-valve, and therefore we are going almost, we hope to double the duration of the valve. So really I think this is something which is today coming very much into our decision process.
Yeah. And Tim, coming back to you, maybe somebody with a particularly small annulus, I mean a large BMI sort of lady with a small annulus, it often produces a headache for us. I mean, how do you approach that when you're choosing?
I think that's right, and I think it strikes me as an increasingly frequent number of those patients. Essentially, I think you've got to try and get as large, was within reason, valve into the aortic position as you can. I think you should really try hard, if possible, to get a 23 millimeter pericardial valve in of various manufacturers into that position if you can. I do think that aortic root enlargement increases the risk of the procedure, particularly in the elderly. It certainly increases the cross-clamp and the bypass time. And in this group of patients, there's the potential to use the sutureless option because it's possible to implant a relatively larger valve with a larger effective orifice area than with a stented option. There are, of course, some issues related to that. It does alter to some extent the nature of the surgery due to the need to make the higher aortotomy, but certainly it's a strategy that may well help with those patients.
And Paul, we see quite good results with the aortic valve replacements by TAVI, but there still are quite a few complications. I mean, the pacemaker rate is quite high, and there is a regurgitation rate. Do you see that in your practice? Do we see that as a real disadvantage, and which might mean that the sutureless or a mini AVR is a good alternative, especially in younger patients?
Yes, and I fully agree. And one of the important things is, of course, the first operation should be a good one, especially in a very young patient, and then you should be able to implant a large valve, because otherwise a valve-in-valve will never have an optimal result also. So the first operation is very important. Considering the rate of pacemaker implantation certainly is important. So the lower the valve comes on the septum, probably the more you have this. This is inherent in the design, and we should work on diminishing this complication.
So we're seeing minimally invasive aortic valve replacement becoming more and more common. Francesca, you're very expert in this, as all of you are. Do you think the future is a minimally invasive aortic valve replacement as the standard procedure for lone AVR when they're not at overly high risk, and what makes that operation easier for surgeons?
Well, in our practice, all the valve surgery is done through a minimally invasive approach. So for us, it's quite a standard approach, yes. It's certainly an operation that requires proper training and needs to be learned properly. So like everything else, I think we need, certainly it's a better option compared to full sternotomy because the less incidence of complication and much smoother postoperative course. But we need proper training for young surgeons to learn this type of approach because there are a lot of little tricks that needs to be learned to make the procedure safe. Working on a small space, particularly for aortic valve replacement, really you have to be very precise. There is no space for a second go sometimes. So really this requires proper training and proper learning. That's why we, as I said, this is something, maybe it's worth discussion, but when I say training means not only of people coming and watching, but means also a very close proctoring and follow some through the procedure until really he gets confident in the procedure itself.
And Tim, I know you do a lot of sutureless sort of valves and minimally invasive. Is that easy to train, and is it the same operation as a sutured valve?
I'm not that experienced in minimally invasive cardiac surgery, but we have got extensive use with the sutureless valve. Certainly that valve and that valve technology lends itself to being used in a minimally invasive setting because of your ability to be able to deliver the valve from a slightly higher position and not need to get down to the level of the annulus to perform suturing, such extensive suturing.
Yeah, and Vinny, is sutureless once it's in there? Is that the same valve as a sutured valve, and is it easier to teach and easier to perform?
It's not easier to teach or perform to start with. I always define it as it's not a difficult procedure, it's a different procedure. I completely agree with what is previously said is you have to learn important tips and tricks, and it's easy to learn it if you pay attention to detail and start from zero level rather than try and put your own tricks to start with. So it is different. We have a very large experience in minimally invasive and sutureless now. These two sometimes have a different learning curve themselves, and it's important that we learn one thing at a time and then go on and put on the learning curve of the other technique. If you try both, there's a higher chance of disappointing results.
Yeah. And Paul, there might be a lot of surgeons out there going, I wish I could have a go with mini AVRs or sutureless, but I mean, in Belgium, are the barriers financially, or what are the barriers to people adopting these novel techniques?
Well, for mini-invasive, there's not such a barrier, and we have for the young cardiothoracic surgeons in Belgium, we have a specific training program where they can learn the anatomical tricks in the anatomy lab, and this is really helpful, and that convinces them that it's possible and that it's fair to do this, that it doesn't need extraordinary skills, and that you can train on this safely. So there's a huge adoption rate once they got convinced that it's possible without additional problems for the patient.
And Francesca, you just said you do virtually all your isolated AVRs minimally invasive. I kind of have heard that, across Europe it's maybe 10, 20%. I mean, do you think this should be 80%? Or do you think variety is okay? Or should we have randomized studies? Or really, should this be rolled out now?
Well, as I said, of course, because this is our approach, I am convinced that the indication for and the use of minimally invasive approach should be expanded. And probably there will be not much of a difference between the techniques. But certainly, as I said, it's for the patient, it's a better approach. In fact, in my experience, I believe that sicker patients, obese patients, patients with lung dysfunction do better in the post-op course with a minimally invasive approach compared to full sternotomy. So I think there is probably room for a randomized trial to see exactly which are the clinical settings where a minimal invasive approach could provide better outcome compared to a full sternotomy.
And if Tim, if you were making policy in the UK as whether we should be rushing towards minimally invasive or we should wait for studies, where would you say we should be positioned at the moment?
Well, I think it's very, very interesting. The issue related to the UK clearly is around health economics. It's around whether these more advanced minimally invasive techniques are more expensive. I think the technology is here now, but it is the issue is to convince commissioners and purchasers that this surgery can go ahead. Undoubtedly, the way forward within the UK, as you know, is to convince NICE, National Institute of Clinical Excellence, about the effectiveness of the treatment, about the potential for better outcomes in patients with increased amount of comorbidities, and that will have to almost certainly be through a series of clinical trials, which are currently being undertaken within the UK. In fact, one is taking place in Middlesbrough in your unit, and we're very much looking forward to seeing the results of that, because that may well help take this further forward within the UK.
And Vinny, in the young patient, we see 80% of valves biological, but a 60-year-old, what is the modern best treatment for a 60-year-old? Is it biological with the promise of further valves, or is it just go with mechanical with a low INR rate? Has it changed?
I think this is very important, because when I trained 15 years ago, the age was 70, and now slowly it has come down to 60. I still balance the life expectancy of the patient and durability of valves, and we always discuss just 60-year age in isolation. But today I think we've got an option. If it's a 60-year-old, and as we discussed before, if you get an average durability at a 60-year-old of 15 years with third-generation stented biological valves of reasonable size, I'm going to probably double it by doing a reasonable size valve in valve later. So I don't have any hesitation, especially if the patient is leaning towards no warfarin. I'm more than happy to implant a stented valve, provided I interrogate the echo myself and assure myself that I can implant, as Tim said before, a 23 size or a bigger valve.
And I suppose just sticking with a second, you've told us so much about sort of valve in valve with your app, but what about the mitral? So if you're doing mitral repair, do we need to think about what kind of annular repair we're doing? And do we need to put a full ring in for just in case? Or is this just, we're not going to be doing valve in mitrals, are we?
I have a very strong opinion about it.
Yeah.
I think, as we know, that valve in a ring is a very new, still the experience all over the world, maybe less than 200. We have seen that amongst the 16, 17 rings which are currently implanted regularly, in terms of valve in the ring, only 6 rings are ideal. One of them is, of course, a Sorin 3D Memo. But I think the ring design, again, there is a potential to change, because the ring is implanted to do a particular function when it's implanted. But if we can also make that ring adaptable later for a valve in the ring, I think it will do the job of both, same as a stented valve, which we discussed before. But I think a ring like, say, a very rigid ring, which cannot be deformed later with a valve, then the only option remains later is open surgery. So I think there is a lot of scope towards changing the designs at present to so-called semi-rigid full rings. Incomplete rings are not very TAVI friendly from my personal experience, because you cannot anchor the valve in a very reliable way at present.
Maybe if I start to draw to a close with a slightly political question from Tim. We've seen the battle of PCI versus grafts, and that ended up in heart teams. Will the battle of what valve procedure, should that end up as a heart team approach for all patients with valve disease?
I think it probably should. I think the most important person often in these discussions is not there. That's the patient. And I think that the various options available and what we feel is almost rank or prioritise what we feel the best choices for the patient are, and then they should be presented to the patient. I think a very strong way of seeing patients with valvular heart disease is for the cardiac surgeon and the cardiologist to jointly see the patients together. I have some experience of this in a peripheral clinic which I've been involved with for several years, and it is certainly a very powerful, very good way to get the information to the patient and their family about the choices that are available for their valve surgery. And I would recommend that. I would think that that's almost a best practice that we should aspire to.
Yeah, well, that's an absolutely fantastic thought to finish on, perhaps, and I suppose hopefully inspirational for patients to actually have them involved and have every choice. So thank you very much all for coming. I think the future is interesting. It's exciting. There's all sorts of opportunities out there for different types of surgery. So it's an exciting time to be a surgeon. So from myself and everyone at CTS Net, I'd just like to say thank you very much.
Thank you.